My name is Suzanne Beers. I'm a urology consultant working at Adlib, subspecialising in female and reconstructive surgery. And I'm very pleased to introduce our panel as well. So we'll do that individually as everybody comes up. We're looking at basically the best of BAUS at the beginning of the session, and then we're going to look at the highlights of the urological year, including the most salient and important publications worldwide over the last 12 months, which should change all of our practices. We're also going to collate all this information that we're providing for you today, because it's been a lot of work for all of our speakers, and we'll provide an article in the JCU just to summarise it as well. So the first person I'd like to invite to the podium is Mr. Frank Keeley, who's a consultant at Southmead Hospital in Bristol. He's subspecialising in endourology, urinary tract obstruction, and urothelial carcinoma and laparoscopy, and he's trained in both the US and the UK to give us a nice broad opinion, and he's talking on endourology highlights. Thank you.
Thank you, Suzanne. Just a confession, I don't do much general urology. I don't work in the DGH, and I don't have a perspective of what's best for all of you in the audience, but I'll do my best to try to cover it. It's hard to get the balance right, but I'll try to be inclusive and yet not too inclusive. So firstly, what's been happening here at BAUS? We had an excellent session yesterday for endourology. Probably the highlight and the best poster was the MIMIC trial, which really was an observational, prospective data collection from the people at Burst. So these are urology trainees, and on top of their busy work clinically, they collected data on over 2,000 patients with ureteric stones. Roughly half had been given medical expulsive therapy, typically tamsulosin. And I suppose for those of us who are involved in the SUSPEND trial are very aware of it, it's no surprise that there are no differences in outcome when you adjust for size and location. But I think most importantly, it demonstrates a tremendous commitment to clinical research and cooperation among Burst members. There's some notable basic science. I was told not to cover this, but I feel obliged to cover at least a little bit of it. Rishi Joshi's group in Cardiff have been developing the USAQUAL Quality of Life Questionnaire, which covers all aspects of stone disease, whether the patient's symptomatic or not, and regardless of location. Very ambitious work. And then the group in Oxford, Ben Turney had a fantastic presentation yesterday from Ms. Howells about a connection between kidney stone disease and any random gene in the entire genome, and found some very interesting things, and this will be a focus, hopefully, for prevention in the future. And finally, the excellent work done by Kay Thomas and Matt Bultitude guys about cystinuria. They've got a huge population there. It is very difficult to connect, unfortunately, genotype and phenotype. Kidney stones are just a little bit too random events, I'm afraid. But the other presentation came from the group that has been working with the BAUS registry on PCNL, and they looked at the entire data set and compared the last 4,000 versus the first 1,000 and then the subsequent 4,000 to see if there are any trends over time, and found that there are more people are doing supine PCNL these days. This is a slightly disturbing statistic. A huge proportion of cases are being done by consultants, suggesting either trainees aren't being given the opportunity or consultants are a bit protective about it. But it's a disturbing trend that trainees are no longer doing PCNLs. The next one was an audit, and usually we think research is far better than audit to answer questions, but this was a sort of take-home message, I think, for all of us who deal with patients who have obstructed kidneys with a multitude of causes. The interventional radiologist put a nephrostomy in, and then they put an antegrade stent in, and then sometimes things fall apart. So this group in Stoke-on-Trent had a large group of patients who had these antegrade stents in. About half the patients had it done for malignancy. Most of the patients were urology patients, but a fair number from oncology and gynecology, general surgery. And a lot of these patients, especially the malignant group, died soon afterwards, many of them with the stent in situ. But a lot of the stents were forgotten, and a lot of patients had complications from the stent, suggesting that we need to do a bit better. And I think this goes for every hospital I've ever worked in. So it really is a take-home message to work closely with the interventional radiologists to make sure patients, their referring clinicians, and everything's joined up, typically with we urologists acting as sort of the SHO for the interventional radiologists. One other poster was on conservative management of PUJ obstruction, and this is work, a very good series with a large group of patients, not tremendously long follow-up, but this group typically were asymptomatic and a bit older. The 5 who needed surgery were the 5 youngest in the cohort. And one patient who refused intervention lost all function in his kidney after declining surgery a number of times. But on average, the renal function maintained itself, and many of these patients were able to avoid surgery. The summary of the literature over the past year was very challenging, but I'll do my best. Endourology used to have absolutely no evidence for anything we do. I'm pleased to report that there are some randomized controlled trials, some of them very difficult to carry out, and I'll take you through a few of them. There's a group in the US and Canada who investigated different ways of breaking stones during PCNL, found no difference between the different devices, so it doesn't seem to be clinically relevant which one you happen to purchase. There was an interesting group, an Italian group, interesting question, that is immediate emergency shockwave lithotripsy versus delayed, and they say delayed is any time after 3 days from presentation, and on average it's about a week afterwards, and the emergency shockwave lithotripsy did far better than the delayed group, suggesting that should be our standard of care. Patients after ureteroscopy were randomized in this study between having a catheter, an external catheter for 6 hours afterwards, and then having it removed, versus patients having an indwelling stent for about a week. And in that case, the patients with a stent complained more and were much less likely to want to have the same procedure. Likewise, after PCNL, patients seem to prefer having a nephrostomy, which is then removed, rather than an indwelling ureteric stent. So there's a theme here. People don't like stents. However, if a patient has to have stents, there are some different tablets being used to try to relieve their symptoms. And it turns out sildenafil, which has also been shown to be true for tadalafil, helps relieve stent symptoms. But apparently mirabegron doesn't help very much. It helps with some of the urinary symptoms, but not enough to reach statistical significance. There's one important randomized controlled trial I thought I'd show you some of the data from, again, a European group that's managed to randomize patients with lower pole stones between 1 and 2 centimeters to shockwave lithotripsy, percutaneous nephrolithotomy, or retrograde intrarenal surgery, otherwise known as flexible ureteroscopy. They found the mean operative time was longest in the PCNL group, shortest in the shockwave lithotripsy group. Likewise, hospital days were quite a bit longer in the PCNL group, no surprise there. But the need for retreatment was over 60% in the shockwave lithotripsy group, and the need for auxiliary procedures was again statistically greater in the shockwave lithotripsy group. The stone-free rate was lower in the shockwave lithotripsy group. And it seems on balance that the flexible ureteroscopy group had the best overall outcomes in this group of patients. So what did this study add? I'm afraid we already kind of knew a lot of these outcomes, so I'm not surprised by any of the numbers they've reported. And unfortunately, a great limitation of the study is that they had no data on patient-reported outcomes at all. So it's really kind of an old-fashioned endourology study, stone study, where we just look at facts and not ask people what they would like to have done. This will hopefully be addressed by the PURE study, which Sam McClinton is leading, where the primary outcome in this a very similar group of patients is primarily patient-focused. And likewise, Sam has come to we finished recruiting to the tissue study, which is ureteric stones, shockwave lithotripsy versus ureteroscopy. And in this case, again, there were clinical outcomes, and then the economic outcomes include quality of life reporting by patients. And you can see in this that the shock lithotripsy group ended up having, some of them had ureteroscopy, what have you. These are preliminary results, and effectively, we don't know what the outcomes are until they crunch the numbers, I believe, in September this year, when they have to report back to the grant holders. So watch this space for that one. There is quite a bit of work done on quality of life tools. So we have the Cambridge group, led by Ollie Wiseman, has done the Cambridge ureteral calculus patient, or the PROM. So CUSP is the short acronym for that. That's been published in the past year. Again, as mentioned, Rishi Joshi's group in Cardiff have been working on this comprehensive stone quality of life tool. And then Andy Portis from Minnesota reported that just asking people how much pain they're having is a good predictor for whether they might eventually need intervention for their stones. So he kept it extremely simple. There's now going to enter into the non-randomized controlled trials, but still offering us quite a bit of evidence. We've had the privilege of having Ben Chu here this week, and he presented this in more detail in the last session. But this EDGE Research Consortium effectively are trying to answer questions that matter to us, but probably wouldn't get funding for randomized controlled trial. So whether you use a laser to dust the stone or take out all the bits is something we all argue about, but is not really worthy of funding. So he found that the dusting group, unfortunately the two groups were not comparable. The dusting group had larger stones. The stone-free rate was higher with the basketing group, but it took quite a lot longer to get the case done. So a mixed outcome. Am I surprised by this? Not particularly. Does it really matter to take out every last piece? Perhaps it's not quite as, patients don't notice all that effort you put into it, so perhaps dusting is a reasonable thing for many patients. One, again, observational, non-randomized study I thought was worth highlighting because this is a common scenario. Patients, this is a small study in Iowa where they did ureteroscopy and left a stent in with a string attached, and then decided to change their protocol from leaving it in for 7 days to leaving it in for only 3 days, thinking patients would thank them for having their stents out sooner. And their outcome measure was need for any medical assistance, that is phone calls, emergency room visits, anything they were in some distress over. And the 3-day indwell time group had a much higher reported need for medical assistance. So perhaps if you're going to leave one in, 7 days might be, it seems cruel sometimes, but it might be kinder in the end. And then some rarer things. There was a good study from, again, North America, just looking at 10-year outcomes for this fairly rare condition, ureteric strictures. And I think the highlight for me is that only 25% of patients, roughly, were able to be managed purely endoscopically with 10-year follow-up. So and a lot of them ended up having a nephrectomy. So this is a bad problem to have, and we do all sorts of things trying to be clever, but ultimately, endourology has its limits and perhaps shouldn't be tried over and over and over again. And then something new, a buccal mucosa graft for ureteroplasty, that is for the same condition, or perhaps for revision pyeloplasty, should be something we should have in our armamentarium. And then I'll go on to the really things that just thought-provoking as opposed to things that are coming soon to your practice. There's a study from America, but based on NHS prescribing habits, showing that antibiotic use in the year before was associated with a higher incidence of kidney stone episodes. I'm not sure what to make of it, but they were pretty adamant in their statistical analysis that it was a significant association. If a patient has a stone and you're trying to predict whether they'll pass or not, you can use ultrasound resistive index in the kidney, and if it's high, that is, if it looks obstructed, then they're very unlikely to pass their stone. And then there's quite a lot of work about oxalate absorption in the gut, and this may lead to some breakthroughs in terms of calcium oxalate stone prevention. And finally, a herbal remedy. I have trouble as an American saying herbal, but I'll still, it's better than saying the alternative. this tablet here is a herbal remedy which has been used in Latin America for years, and it turns out it does alter in a very positive way patients' 24-hour urine biochemistry. So now I'm going to enter the evidence-free zone of trends on social media, and this has gotten more attention than anything else. Some very adamant advocates of supine PCNL claiming, you're wrong to do it prone. There have only been 2 randomized controlled trials, very small, very poor evidence base, numerous case series talking about how wonderful I am as a surgeon doing it supine typically. And out of these 2 randomized controlled trials and case studies, there are 20 systematic reviews and meta-analyses trying to, polish some brown material. And it's led to thousands of tweets. Again, no evidence, but the conclusion is everyone's entitled to their opinion. Single-use ureteroscopy, I'll finish up with this. I do think this is possibly coming to a hospital near you if it hasn't already. Apparently it's up to about 10% of all flexible ureteroscopy cases in Europe now. It's always been difficult financially in the NHS due to low tariff for ureteroscopy, but there are perhaps some costs to cleaning scopes and breakage that we don't see. It has been shown to be financially viable in the US, and perhaps in the private sector in the UK, it might make sense. But because I think most of the costs of maintaining and cleaning scopes are hidden. Thank you for your attention.
Stay there. Hello. Oh, yep, it's on. Thank you. So that's an excellent overview. I think the take-home message for me is get stents out, treat stones quickly, and obviously a lot of benign surgery, cancer targets get in the way, and it's getting harder and harder for my stone colleagues and myself to get stones into theatre in a timely fashion. I think the evidence is building to try and improve that situation. Can I take questions from the audience for Frank, please? And if anybody wishes to send any via the app, we've also got that facility today. If you come to a microphone and then just wave madly.
Just a moment, Suzanne. I'll just say, further to your take-home message, there's something that I didn't mention here, which is the Simon Harrison's excellent talk on GIRFT, if I can use that term.
Yes, yeah, that as well.
People understand, get it right the first time. And he has highlighted that lithotripsy provision is something that ought to be available in more hospitals and to more patients on an urgent basis for ureteric stones. And I do think that fits in well with the data that we've had this year.
Okay, I'll start the questions off. Frank, so with the issues of getting into theatre and the fact that we're finding, patients aren't liking stents, should we be changing our practice? Should we, for very straightforward stones, maybe distal stones, be putting in ureteric catheters rather than stents? And if we are putting stents in, should our gold standard now be to leave that stent in for 7 days? Some people's practice is to leave the stents on strings. Is that still feasible?
Yes, I suppose there's been a lot of evidence, and it's taken a long time to filter into routine practice, that stents are not required after most ureteroscopy procedures for a ureteric stone. It is difficult sometimes to change practice because it seems like the safe option to put one in. I do think if you're on the, wondering yes or no, a ureteral catheter for 6 hours is an odd thing to do in a way, and it might, it's something I used to do back a long time ago in Edinburgh, but that was when people stayed overnight. And I think with day case, people are accustomed to people getting in, getting out, and so I think a stent with a string for 7 days is a reasonable compromise for patients you just feel too nervous about and you feel like you need to stent them. But having a plan to take it out and making sure they get a date to take it out before they leave is crucial.
Okay, thank you. No, okay. And then the other thing I think from your talk really, if we're coming across ureteric strictures, it's reasonable maybe to have one attempt at an endoscopic treatment for that, but maybe then refer on to your reconstructive colleagues, would you say? I think, to me, that makes perfect sense. I think that the practice even among tertiary care facilities around the country varies hugely. And it does depend on the relationship between the endoscopic surgeons, you might say, and the reconstructive surgeons.
I happen to be both, so I can talk to myself and decide.
Lucky.
But it is, sometimes there's a little barrier there to say, I can fix this, and pride gets in the way. And I would say one go, perhaps, and there's also evidence to say, depends on how long the stricture is and location, what have you. So there are certain patients, the ureteral ileal strictures after cystectomy don't tend to do well with endoscopic management. It's probably best not to start for most of them. So there are patients, and again, futility of treatment is something that's hard to recognize sometimes when you're doing it.
Okay, I'd like to just say a big thank you to Frank Keeley. Thank you very much. I'd like to invite Mr. Mo Bilal to the podium now. Mo is a urology consultant subspecialising in male and female incontinence and reconstruction, and runs several urodynamic courses, and he's working at Queen Elizabeth Hospital in Birmingham.
Sure, before I start, I found a phone.
Yeah, it's...
Guys, thanks very much. So the talk's going to be obviously a bit about Best of Baus and then a bit about the rest of the year. So I'll probably do 8 minutes for the first part and another 12 minutes for the second part. So I finally had to turn up to every bit of Baus in order to do the Best of Baus. And so this is the highlights I thought. And I'll go through some lecture-based, some debate-based, and also some potential new developments in the field of overactive bladder. And then the tried or tested session on UTIs too. So Arun Saha from Guy's, he did an excellent talk on perspectives of nocturia, and certainly we see so many patients with nocturia, and I think we tend to perhaps not realize how much of a bothersome symptom it is, and I think he went through all the evidence, and indeed part of the problem is how to define nocturia, and then the different parts of nocturia, including polyuria. And the problem is not just with old men, it's with women, it's with younger men, and one of the key parts of his talk, which I thought was fascinating, was that actually sleep disturbance has a huge impact on health consequences, including mortality. So there's an association with nocturia and mortality. And one of the key things is actually your first uninterrupted sleep period is crucial to how refreshed you feel or not. And I'm sure some of you have realized that after attending Baus. And Tango is an assessment which has been published, and again, it helps in terms of how to assess these patients. One of the take-home messages were actually we probably should be using a lower dose of desmopressin, and certainly the 50 micrograms and the 25 micrograms, I suspect formulations will result in a higher prescription rate. So certainly under the age of 65, you no longer need to prescribe those, no longer need to monitor the serum sodium. There's an excellent debate with Tamsin Greenwell and Vasdev about reconstruction, and as whether or not you would perform robotic reconstruction or open reconstruction. And certainly from that debate, it was quite clear at the moment the cost of a robotic reconstruction is significantly more. It's almost £3,000 more in terms of the near bladder and almost £1,500 in terms of an islet conduit. And then begs the question, what's the additional advantage? But unfortunately, it was clear that the length of stay was no different. And surprisingly, outcomes were significantly different. The robotic outcomes were much worse than the open, and I suspect there may be a learning curve. And the upshot of it was that certainly we need a closer coordination between the oncology surgeons and the functional reconstructive surgeons to try and improve this in the future. So we had an excellent talk from Professor Goldman from the Cleveland Clinic. He went through all the new types of electrostimulation, some of which was new to me, including the dorsal genital nerve stimulation, as well as pudendal and sacral. And there's some interesting and fascinating new developments, including implantable PTNS, such as the Blue Wind, which I suspect in the future will probably change the electrostimulation market in the UK. There's some fascinating talks about radiofrequency ablation within the bladder. There's two forms of that. One is in the trigone to try and improve symptoms, and there's a sort of segmental one, and certainly that may well show promise in the future. What I thought was also fascinating was how to deliver medication, and certainly Botox, and certainly there's some work done on liposomes, which can instead of actually performing a flexi and injection, you can actually put the Botox into these lysosomes and instill into the bladder. Obviously, that's some way away. And there's also this hydrogel, which is essentially liquid in room temperature, and in body temperature, it's more solid. So you can actually, therefore, theoretically instill medication or even Botox, and we'll wait that in the future. UTIs, the same old arguments of UTIs, how to define UTIs. And Chris Hardy went through all the evidence for the pills, and certainly there's good evidence for prophylactic antibiotics. The Hiprex, there is some evidence, and similarly for D-Manos. I know Chris is performing the Altar trial looking at Hiprex versus prophylactic antibiotics, so we'll wait that. In terms of the potions, unfortunately, I don't think cranberry, the evidence is quite there, and same with vaginal vaccines. Certainly there's some evidence with gag and estrogens. But suffice to say, there's very much minimal evidence in terms of procedures for rare care and UTIs. So how about the posters? So I think one of the interesting posters was to use one's own fat to stimulate regeneration. And certainly in the population of the UK, there'll be plenty of fat to use. And I think what they did was they obtained the fat, and they used a particular type of scaffold, a tissue scaffold, and they changed the fat to nanofat, which sounds quite fancy, but it involves putting a syringe into another syringe and emulsifying the fat. And what they showed was that it was a viable option. The cells produced collagen. And so certainly I think that's going to be perhaps the future for using autologous tissues, as you know about the mesh controversy. This was from Tamsin's group and Professor Mundy. They looked at bladder neck artificial sphincters in women. And they performed it in two fashions, in a two-stage fashion or a one-stage fashion. And they had approximately 30 patients. And these tend to be quite a difficult group of patients. And they had a very good cure rate, though they do have a quite high explantation rate for acute or chronic infection. But we'll have to wait and see how that pans out over time. There was an excellent talk about the long-term outcomes of Mitrofanoff, and this was certainly the largest series of Mitrofanoff patients and in terms of outcome. And the overall success rate was pretty good. And as we all know, there's always a revision rate with Mitrofanoffs, and I think part of it is because it's a difficult operation, but in terms of having a 50% endoscopic revision, that's perfectly acceptable, and a 40% open revision. So continue doing that. So now we're going to move on to the updates of the year. So in terms of the trials I'll be talking about will be the Antic trial. The Master trial has finished recruitment, which is a trial looking at sling versus artificial sphincter. The Alta trial has also finished recruiting, and that's looking at prophylactic antibiotics versus Hiprex. Marcus Drake's finished recruiting with the Upstream trial, which was looking at urodynamics versus outcomes of TURP. And I think Hashim from Bristol also has finished his trial of Unblocks, which is thulium laser versus TURP. So I'm sure that will be presented soon. You can't really talk about mesh in this section without talking about it. And there's been a few additional information with regard to that. And then the age-old problem, whether you should give SNS or Botox, we'll go through that. And then something novel for me, which is the prostate artery embolization. So the Antic trial, which is done by Professor Robert Picard, it's a 12-month trial, and they're looking for a 3-month follow-up following on from that. And the patients were randomized, and they were randomized to either oral antibiotics, such as nitrofurantoin 50 milligrams, trimethoprim 100, and cefalexin 250. The inclusion criteria was the patients had to be self-catheterizing for 12 months, and they had to have at least 2 UTIs in the previous year or be hospitalized for a UTI. And obviously the control group, there's no prophylaxis. The outcome, the primary outcome, not surprisingly, was how many symptomatic UTIs did they have. And there's some secondary outcomes about resistance and about the cost effectiveness. So if you look on the right, it's clear that in green is the no prophylaxis, and the prophylaxis is in black, and there's actually a clinically significant difference. It goes from a median of 2 to a median of 1. In terms of frequency, if you look at the black lines on that sort of histogram, it's clear that there's a high incidence of more than 2 or 3 or 4 UTIs with no prophylaxis. So it does have a very significant effect. Well, what's the downside? Obviously, unfortunately, a degree of resistance. These are the normograms from different antibiotics. There's amoxicillin, cefalexin, Cipro, and nitrofurantoin. And there seems to be an increase in resistance, and this is from isolates from urine or swabs as well. How about the cost? Well, the use of prophylaxis will cost you an extra £99 to prevent one UTI. Having never had a UTI, I'm not quite sure if that's value for money, but I suspect it is. And actually, interesting, the patients weren't concerned about using antibiotics in terms of the quality of life. And then they weren't even particularly concerned about the development of resistance. So I think that the take-home message for the ANTIC trial is certainly if your patient's self-catheterizing, I think there is now high-level evidence to suggest it's worth giving them prophylactic antibiotics. But the concern in the longer term is whether or not they'll develop resistance. So we'll wait and see what happens. So MESH, the bane of a functional urologist's life, there's been 2 publications. One was from NHS Digital, which was recently published in April. And again, it's used HES data, and they were retrospectively looked at in terms of surgery for both prolapse and for stress urinary incontinence. So almost 200,000 people they looked at, almost divided 50% each in terms of urogenital prolapse and urinary incontinence. So what does the first thing show? Well, it shows quite remarkably there's actually a massive reduction in terms of surgery. And so from 25,000, you've essentially gone down to about 17,000, and that's including prolapse and stress urinary incontinence. Since most urologists don't perform prolapse surgery, well, let's have a look at stress urinary incontinence. So in 2008, you had 14,000 procedures. Now you've gone down to approximately 7,000 procedures. So it's over a 50% reduction in terms of activity. How about in terms of tape removal within 30 days? Well, I think there's probably a slight reduction in tape removals in 30 days over the last 10 years or so. So I don't think perhaps the patient selection is better, the surgeons performing this are better. And how about non-tape procedures? Well, you probably see it's fairly consistent. That's not increased over time. And how about removal after 30 days? And this essentially shows that back in 2008, you had a much higher instance of tape removal after 30 days within the first 2 years, about 3.9 per thousand compared to 1.8 per thousand 10 years later. So actually, the number of tape removals has reduced. So the take-home message of this snapshot survey is that certainly there's a massive reduction in terms of stress urinary incontinence surgery. There's no increase in non-mesh surgery, meaning such as an autologous sling or a Colpo suspension. But actually, despite what the mesh groups say, the actual tape removal is quite low. There's another study on a similar sort of basis, which also looked at complications of a significant proportion of people, of almost 100,000. And again, the activity clearly shows transobturated tape, TVT, is on the way down. An autologous sling hasn't increased at all. And in terms of readmission rate, after a tape, it's most common within the first 2 years, after which it tends to drop off. How about further surgical complications relating to the mesh? Essentially, you're 94% free of surgical complications after such mesh procedures at 5 years. So actually, it's a relatively low complication rate. So the take-home message I didn't mention about the complication rates is that actually mesh surgery complications are low, and it's 2.4 for TVT and less for TOT. They looked at the unconfounded groups in the patients who just had the mesh surgery with nothing else, and that's 94%. When they looked at a confounded group, it was slightly higher at 10%, but actually the type of complication was not reported in detail, so it could have been retention, so that was perhaps not so helpful. How about some further data? So there's an updated meta-analysis looking at the different types, published recently last year in the European Urology Journal, and they looked at 28 randomized controlled trials with almost 16,000 patients. They did a lot of forest plots. I'll just do the highlights of all the forest plots. I went a bit crazy. They had about 20 forest plots. So the first one is to look at the midurethral sling versus a Colpo suspension in terms of overall cure rate. And essentially, that shows that the midurethral sling has a better overall cure rate than a Colpo suspension. How about an autologous sling, which is what some of us are doing more of? And actually, they're pretty much equivalent. There's no difference between the two. The only thing to say about the autologous sling, which is the pupil vaginal sling, is that there's a higher incidence of storage LUTs following such surgery. And how about TVT versus TOT? And essentially, the overall cure rate is not different. But if you drill down to the data, there's an objective difference between the two. So what does this tell us? Actually, it tells us that since everyone no longer wants mesh, we're going to go back to copper suspension or autologous slings, that perhaps the results are not going to be as good as certainly the copper suspension. And the autologous sling will probably be equivalent in terms of success, but there'll certainly be more storage symptoms following that. In terms of retropubic or transobturator, I don't think there's a major difference between the two, but actually the retropubic approach has objectively more complications. So this is a follow-on trial from sacral neuromodulation versus Botox. So they randomized patients towards sacral neuromodulation and 200 units of Botox. At the time, this was criticized as 100 units of Botox is what's commonly used. And for the SNS group, they were considered an expert if they're putting 10 implants. In terms of the type of demographics of patients, they're pretty much the same. Now, in terms of the primary outcome, which was the change from urge urinary incontinence, as you can see, at 6 months, there's a difference. But actually, at 24 months, there is no difference in terms of cure rate. And if you look in terms of whether it's complete cure, or if you look in terms of 75% reduction or even 50% reduction, actually is perhaps swinging towards the favor of sacral neuromodulation. How about the quality of life income? Interestingly, at 24 months, there's actually a selection towards Botox. But if you drill down on the data, you realize that actually it's a selection bias. They've lost about 10 patients who've actually, for whatever reason, no doubt they're not satisfied with Botox or not included. And I suspect that may just be a statistical abnormality. In terms of adverse events, the main differences, not surprisingly, are rare care and UTIs for the Botox group, but pretty much all the adverse events were pretty low. So all in all, you can say that actually SNS and Botox are pretty much equivalent in terms of the outcome at 2 years. The adverse events are generally quite low. I'm not so convinced about the higher satisfaction for the Botox, as mentioned earlier. So now moving on to something different, to BPH. And so this is looking at the UK ROPE study, which is the prostate embolization study. And they recruited, it's a registry, so they recruited over 300 patients in multiple sites. Some of you may be involved. And in terms of their primary outcome was to look at symptom life outcome in terms of the IPSS and any complications potentially. So what does it show? Well, actually interested that there is a reduction in the IPSS, obviously not as much as a TURP. And also in terms of the Qmax, there's a marginal improvement in the Qmax, and also in the prostate volume as well. How about reoperation rate and complication rate? In the prostate artery embolization, you've probably got a 20% reoperation rate. In terms of the complications, I'll point out the penile ulcer complication, which was the, I think, embolization of the accessory vessel of the penis. And I understand they had that ulcer for 3 months. So I would personally say it's more than Clavendino grade 1 for the patient, but you may beg to differ. So how about NICE? So NICE have actually said that they support the use of PAE, but they need adequate training. It has to be done by a urologist and an intervention urologist, a radiologist, and it should be done in certain centers. And I think that's it. Thank you very much.
I'd like to invite questions from the audience, if you'd like to go to the microphones. Just while we're waiting for audience questions, I think one of the interesting things that will probably change my practice from the female section this year is really the role of nocturia. I think we often don't diagnose it. I think frequency volume charts are often inadequate and they're slightly poorly designed to show it. And also the emphasis from the talks we've had that it's really a multidisciplinary problem. And we try to do our best in urology, and we ask people to put their feet up and take furosemide, and we heard that that paper really comes from about 18 patients from a study in Oxford many, many years ago. So that's something probably as clinicians we can do better with. Mo, is there anything that has come up in the last 12 months that will change your practice or has changed your practice?
No.
Yeah, okay. Enlightening, isn't it? Mr. Keeley.
Yes. I was wondering about, you mentioned that the mesh insertions are way down. The other procedures don't appear to have gone up.
No.
So is everyone just getting risk averse and we're neglecting patients who might benefit from your expertise?
I think it's a combination of the patients not actually attending. And I think, unfortunately, a lot of patients are scared by the mesh. I also have male patients for male incontinence, and they all, you know, if you offer them a male sling, and they always go on about the mesh, and you have to go through the different anatomy. So I think it's partly the patients themselves aren't attending, and partly I think the clinicians are more reluctant, perhaps, and they're more conservative than they used to be. And so now the counselling for anti-incontinence surgery takes about 5 times as long as the operation does, and so I think that puts people off as well.
And have you found that's it? Oh, so we've got a question at number 1.
It's not really a question, but it's the most remarkable stat I've heard this year at a urology meeting. It was at the Australian meeting. It was a presentation by Eric Rovsner from South Carolina. Do you know what the single biggest settlement in the United States is for mesh removal this year to an individual?
40 million?
$100 million to one individual. And I went to the mic and I said, Eric, how can this sort of surgery carry on if that is the potential downside? So I suppose that is a question to you, Mo.
Yeah, well, I think the cost of litigation for mesh has gone exponentially, and I think in Scotland it's no longer allowed. In Australia, I think in a way, if you look through our history, it's almost like a witch trial, isn't it, in a sense? It similarly happened throughout surgery, throughout decades, where there was a silicone implant in America. Actually, there was not much evidence. But once the hysteria builds up, it actually makes it very difficult. And it's a shame because we'll end up going back to the old style of operations of the Colpo's suspension and the autologous slings, which do have significantly more morbidity. But I suspect it's patient choice, and I suspect we'll probably find that this is where we're heading, and we just have to accept that and just counsel the patients as well as possible. And I think it's now more about counselling than it's actually about the surgery.
Okay, thank you very much. Oh, sorry, 2, Roland, sorry.
Yes, it was just going to be a word of caution about implants in general, because I know the mesh has brought it up, but actually the 2 things that were driven forward, FDA said when meshes came out, post-marketing surveillance was needed by the mesh companies for these products, and they didn't do it. And secondly, they advocated that we should be only implanting these initially within a controlled environment, and that didn't happen. So it really begs the question going forward, with new implants, we need to be very, very careful about how we manage them and how we put them in. Because they may be good, they may be bad, but we have to manage them properly.
That's a very good point. Okay, all right, thank you very much.
Sure.
Okay, I'd like to invite Ari Parnham to the podium, please. So Ari works at the Christie Hospital in Manchester. He subspecialises in penile cancer, erectile dysfunction, penile implants, and is heavily involved in European Association of Urology with guidelines on male sexual dysfunction and also penile cancer. And the thing, I went to the andrology session, which was absolutely excellent, and the thing I found out, if you are a man and you take a statin, a PDE5 inhibitor and testosterone, you're going to become immortal. So I just want to know what the cocktail is for women, really. But anyway, you probably won't be able to answer that. Thank you.
Great, thank you very much. So this is the highlight section for andrology and genitoureteral surgery. So starting off, we had a talk by Asif Munir on what's new in the guidelines, and we looked at the EAU guidelines and the BSSM guidelines, which have been recently published. EAU guidelines, not much has massively changed, except there's a slight more recognition of kind of other symptoms and conditions that are tying in, so for instance, male low urinary tract symptoms. And so there's kind of a move now to also recommend doing an IPSS in these kind of patients, or at least asking about these type of symptoms. Further, there's a little bit more evidence out there that's evolving, and we kind of knew it already, but I guess it's kind of emphasized, and that's about depression and how we should really be screening patients, at least screening them, to pick up on these conditions. The BSSM has a slightly different tack in treatment. They've kind of gone for slightly different in the sense that they ask for a early morning testosterone, which is the same in the other, but they suggest that you try and correct this before or immediately before starting a PD5 inhibitor. So they say if you your testosterone is less than 8, you should treat it and start a PD5 inhibitor, and if it's less than 12, you should trial it. Low-intensity shockwave therapy, the ongoing story, this has been going on for ages. The evidence isn't really that mature. It's very heterogeneous. And so as a consequence of that, the EAU guidelines don't feel comfortable in recommending this yet. But BSSM feel a little bit stronger on that, and they feel that it could be used in mild ED or for trying to salvage PD5 inhibitors. And alprostadil, which many of us now will be, especially topical alprostadil, which many of us now will be au fait with, is not mentioned in the EAU guidelines, which is probably an omission at this stage. So I had a talk by Kevin McNally about male infertility, and went through it and basically identified there's 3 parts. So there's the ugly parts, which in other words, there's a decline in fertility that's been proven over the last 40 years. On the bad side of things, there's been a decline in IVF funding, and many of us, certainly in different regions around the UK, especially in England, are noticing that we're struggling to access that funding. And as a consequence of that, many of us are feeling probably quite marginalised in terms of fertility. The good side of it, though, is that the awareness amongst the public is increasing, less of a taboo, and research is certainly increasing, and certainly some of the posters that were presented during this meeting represented that as well. Fertility is a big theme at the moment, seems to be. So fertility preservation in cancer, this was Mad Shabir's talk. He was talking specifically about testicular cancer survivors. And 98% of the people now, as we know, are surviving at 10 years with testicular cancer. But 50% of these are having subfertility, 10% azoospermia. So it's slightly kind of concerning, and certainly there's a variance in practice in that. Some people are trying to cryopreserve or at least get some sort of semen sample sent off prior to treatment, but certainly that's not common practice, I would necessarily say. Looked a little bit at chemotherapy as well, and different chemotherapy regimens and agents. BEP seems to have a medium risk of affecting your fertility, and alkylating agents are high risk, so you just need to be aware of that if someone's going to go on it. Again, another really good reason to kind of sperm bank them well before any sort of treatment. 2 cycles, they usually recover after 12 months. And if you have more than 2 cycles, well, it can take 24 months or even more. And as I said, it's best to try and do it beforehand and avoid the whole issue in the first place. It's worth also noting if you have a single dose of chemotherapy prior to any treatment or after treatment, you cannot use the sperm for 6 months. And so this is the concern of damage to DNA integrity, although that's not really kind of that strong data there yet, but it's evolving in all fairness. Radiotherapy, 16 to 18 gray, causes permanent azoospermia, so just be aware of that. So again, testicular patients, and all of our other patients will come on some data of that later on. And also, we don't really know what's going on with monoclonals and some of the newer agents, so it's very difficult to say what effect they're having. Again, should probably sperm bank beforehand. So this is an algorithm. They're saying, so do an ultrasound testis, bloods, including testicular function, semen analysis, and if negative, for semen, that is, or sperm, then consider an onco-TZ, and obviously that would require training and specialist units for that, and probably some degree of centralization. Circumcision of the beats, this was a talk by Roland Rees. It's a really difficult subject, and certainly for someone like myself who does a lot of penile cancer, and a lot of my patients are obese, it's kind of a very, I recognize this being a difficult and challenging area. And it's about judgment, and talk about risk of burying, pain on erection. Roland gave some really good insights into how to judge that. What was interesting is that a lot of these guys who do have circumcision end up with just having a recurrence of it, and also lichen sclerosis, which we all know is a risk factor for penile cancer in any case. So it's really kind of difficult. I guess the other question is, how much do you circumcise? Do you circumcise them so that it's completely below the corona, by which point you then often leave them with penile, less skin? Or do you just under-circumcise them and allow them just to be able to retract it and keep it dry? Penile prosthesis insertion. David Ralph presented this study by Gross. This is an infection study, and basically looked at a load of implants that have been explanted due to infection, looked at the bacteria that were grown and all the organisms, and found that actually, I thought the interesting part of this was that 11% of those were fungi. And if you look at the current EAU guidelines, the kind of recommended antibiotics in this circumstance don't really cover that. So he was suggesting that maybe we should be thinking about adding in these cases, especially at the beginning, of vancomycin, tazocin, and fluconazole. Also talked a little bit about plaque incision and grafting for those of you who are in the sphere of andrology, or remember anything about loo procedures where you put in a graft. People are moving now, or there's a move to using Tacosil, which is much quicker, seems to have fairly similar outcomes as well. For penile implants themselves, the instruments that we've used often have to be sterilised, but there seems to be a kit coming out soon, which will cost 150 quid, which is significantly less than the sterilisation cost, so that seems to be a move in the right direction. Gender implants seem to be increasing as well, 20% on year. And there was some really, actually, I find this bit interesting about the exciting developments that are coming up, especially from implant surgery. There's the Optimus 2 two-piece implant, which gets rid of the reservoirs per se, of the third part. And then there's also on the far horizon, remote control implants, which brings a whole new sphere of andrology, and memory alloys as well on the horizon. Sanjay Kulkarni did a really great talk. They had two talks, one on posterior urethral injury and his experience of that, and also on his training program that he's got. He talked about multiple failed urethroplasties, and he felt that this was down to inadequate scar excision and bulbar ischemia, and really emphasised that really preservation of deep dorsal artery is imperative to prevent bulbar ischemia and pubectomy. Management of urorectal fistula. We're seeing increasing numbers of these following prostate surgery. Prof. Mundy identified 3 different types of fistula, and all of these, starting from the beginning, have reducing success. So direct ones, usually post-surgery, fairly successful, cavitating less, and when you get a urosymphyseal fistula, your outcomes are pretty dismal. And also highlighted the fact that always, as always, do nothing is an option, and certainly advocated that patients who are in pain or recurrent UTIs should really be considered. And if no radiotherapy, you need to get away with a transperineal approach. So Mark Lucky talked a little bit about erectile dysfunction, neurosurgical disease, not something that many of us come across, but essentially saying that we are really just touching the iceberg, or the kind of top of it, really, and suggested that we should be approaching or using a multidisciplinary approach. There was a study that he presented that showed about 1/3 of these patients suffer from severe erectile dysfunction, and this is proportional to the degree of disability. There's currently a study on this in MS patients called TONIC, which is looking at their outcomes, finding that about 73, so a good portion of these people are sexually active, and as I say, is linked to disability and depression. And he's talked about assessment as well, and how we should really consider it as a primary, secondary, tertiary. So primary as in the actual sexual problem, secondary is the symptoms of the neurological disorder that are affecting it, such as fatigue, and tertiary, which are the psychological effects overall, such as depression, body image, and some people really suffer from guilt and fear of being rejected. So we then went on and had, on the second day, we had a really good talks on preventative andrology, and the idea here was to see if we can treat male sexual dysfunction can improve life expectancy. Andrea Solonia talked a little bit about infertility in this context and found that there was a high risk of all-cause mortality. And also the Charlson score was higher in people with infertility as well versus non-infertile men. And found that also if you have 2 or more abnormal parameters on your semen analysis, you have a 2.3-fold risk of death. It's a bit scary. Azoospermia, highest in testicular tumours, that kind of makes sense from the kind of testicular dysgenesis syndrome, and also your risk of diabetes is high at 2.1. Semi-quoted myself here, but essentially I also talked a little bit about cardiovascular disease and how we all know that, well, most of us will know that it precedes, erectile dysfunction precedes cardiovascular disease by about 3 years. It has the same kind of risk factors, mainly those associated with endothelial dysfunction. And we presented some evidence that PD-5 inhibitors may not just be good for erections, but also may be good for heart failure, specifically heart failure with reduced ejection fraction, and also in arrhythmias that are life-threatening. Jeff Hackett also talked about low testosterone risk factor for developing cardiac disease, which is now in the AUA guidelines, and that all men with increased waist circumference, type 2 diabetes or obesity should be checked and treated proactively for hypogonadism. This was one of the poster presentations. This was talking about redo or salvage microteasy. Many now consider microteasy being the gold standard for obstructive azoospermia with rates of retrieval 50 to 60% depending on who you read. And this was a group looking at 153 patients. Overall success 45%, which is pretty good, about smack in the middle. But when you're looking at negative TZ, so just a standard TZ, and then repeating the micro TZ, your chances of finding sperm were 39%, so better. Those who had positive TZs in the past and they had a micro TZ, obviously more likely to find something, so it's 79%. Those with a negative micro TZ, this is the interesting group, and then you repeat it again, 33% found to have sperm. Why is that? I'm not quite sure. Maybe to do with how the procedures performed, maybe to do with stimulation. Some people are stimulating prior to the second procedure. And obviously, if you have micro TZ that's positive the first time, it's probably going to be positive the second time. So that's the kind of the best of the Baus summarized up. And then on to kind of the world literature. Those of you who do andrology, we very rarely get any sort of RCTs, but there is one in here. So this is looking at basically HbA1c levels in people who are having penile prosthesis. It's always been an eternal question on where is the cutoff line? Where do you decide what's too much? When does the risk become too unacceptable for putting in a penile implant? So this was a study by Habus looking at 4 centers by 16 surgeons, all who were experienced implanters, and they were doing over 30. They looked at the diabetic, the HbA1c prior to the procedure, and they put them into these kind of risk stratified groups of less than 6.5, 6.5 to 7.5, so on forth to 9.5. And they looked at 902 implants, and then they looked at what they found. They found about 8% of these, which is kind of about the middle, well, a little bit high maybe for infection rates overall. The average HbA1c in these patients was 9.5%. In the infected group versus 7.8% in the non-infected group, so there's some sort of association there. And then they drew kind of your ROC analysis kind of curve and found that an HbA1c of about 8.5% gives you a sensitivity of 80% and a specificity of 65%. So maybe we should be looking towards 8.5% as a cutoff. It's not in any guidelines. It isn't fixed at 8.5 yet. There is some guidance, I think, from NICE on that, though. Also, they looked at some other factors to see what made a difference to the infection rate, and we talked about the diabetic rate there, the odd ratio, the HbA1c 7.34 ratio. They had a couple of surgeons, I did slightly miss that out, but they had a couple of patients, surgeons who were not implanting more than 30. So they did kind of look at that as well, and those that were doing less than 30 had a higher risk as well. People who have Peyronie's disease, again, higher risk. We kind of knew that already. And if you're obese, again, another risk factor for infection. So the other question, again, coming back to infertility, and this is a study by Mark Lucky in Aintree and Ben Starmer, and it's basically looking at testicular trauma, and so they basically trawled the literature to see what people have done in the past for fertility in terms of the testicular trauma. EAU guidelines don't really provide anything about fertility sparing in this circumstance, and neither do AUA. So, and this is what they found. They found 10 cases. One of the cases had partial amputation of his scrotum due to a prawn aerator. That's that thing on the side. I never knew that. 8 of these had reimplantation, and of which of those 8, 2 had spermatogenesis, 2 underwent a TZ, and 1 was made to ejaculate post-trauma. And obviously, there's something to bear in mind that the sperm is available for 72 hours after the incident. So they kind of concluded that really you should be liaising with local fertility centres, and in circumstances where trauma, torsion, scrotal exploration, or routine epidural surgery maybe, we should be really putting in our minds to fertility in the background, at least giving the option of fertility preservation. We should also measure our testosterones as well, and we should make sure we send things like Hep B, core surface antigens, Hep C, HIV as well, so we've got the options to preserve. This made a lot, I don't know if anyone, those people who went to EAU and read The Sun or anything like that, this was a big article on The Guardian as well, looking at management of penile cancer. And essentially, this was a study looking at 425 patients across 12 centres between 2010 and 2016. And they retrospectively looked at how they were managed and compared them to the EAU guidelines to see how they differed. And this is what they found. So for the management of the primary, i.e. removing the actual lump on the penis itself, there was about a 74.8% adherence. That was a big headline. A quarter of patients were being mismanaged. And also in the groins, roughly about the same number, 73% as well. If you follow the guidelines, or if you don't follow the guidelines, it seems to make a difference as well. So if you can see from these Kaplan graphs here as well, that by following the guidelines, your chances of survival seem to be better. Okay. Early versus delayed PD-5 inhibitors in post-prostatectomy rehab. this seems to be a kind of, again, another one of these recurring subjects, but this is quite interesting, I think. So basically, they looked at patients who were going to have a nerve-sparing or tended to have a nerve-sparing surgery. They had PSAs of less than 15, Gleason less than 7, clinically less than T2C. They were over 50. They had to have an IIF score of over 17, and they were randomized to either receiving sildenafil immediately or sildenafil 3 months later. And they had their SEP scores measured at 3, 6, 9, and 12 months. And if you can see, those that received sildenafil early seem to regain their erections earlier, so 41.4% had gone back to above 17%, versus those that received a delayed sildenafil at 3 months and then onwards at 17.7%. If we look at the kind of cancer treatment, this was going back to Magister Beer's talk a little bit about fertility, but also about endocrine dysfunction and the consequences of treatment of cancer. This is a study looking at childhood cancer survivors and testicular cancer survivors and seeing their, the effects on their gonadal function. So childhood cancer survivors, there are 427. Between 1970 and 2002. They then went back in 2009, between 2009 and 2013, and questioned them. So they asked them about the height, weight, smoking, did testosterone function, FSH, LH, and SHBG, and then compared them to a control group, and they did the same for testicular cancer. You can see the numbers. And they found that those who were childhood cancer survivors, about 26% of these at this delayed point still had hypogonadism. 14% in the control group with an odds ratio of 2.1. And they looked at different factors that may affect it. So if you had some sort of testicular radiation, this kind of makes sense that your odds ratio is significantly higher. If you had cranial radiation, it was pretty high at 4.4. And if you had chemotherapy and radiation to anywhere else except for the brain and to the testes, your odds ratio was 3.7. So obviously this is something that's kind of staying with our childhood survivors. And you can then bring that into kind of testosterone and cardiovascular risk long term. You just wonder whether we should be following these guys up a little bit closer. And the same for testicular cancer here, 36% were found to be hypogonadal at that delayed stage with 2.3. And if they had more than four doses of chemotherapy with cisplatin-based, then the odds ratio of having hypogonadism was 17. If you look at the new guidance that's out there, there's some new guidelines. Priapism, this is really, I recommend anyone who deals with these type of things to have a little look at them, even if you don't. This was a consensus statement, so there's the guidelines on priapism. There's a really good diagram in there, and there's also a little bit of a consensus. There's a consensus statement also on testicular trauma. So this is it. This is the ischemic priapism one, and this is by Asif and the group, and also the testicular trauma, which was led by Mark Lucky as well. That's it.
Thank you very much. I'd like to invite questions from the audience or the panel. Ari, from what you're saying, it almost sounds like GPs often offer men a health check, and I wonder if we need to expand that in urology. Do you think we should be, offering to see men at a certain time, or if they develop erectile dysfunction? It sounds like they need a waist circumference, they need BMs doing testosterone, around semen parameters. Do we need to change our practice to try and kind of anticipate heart disease, cardiovascular disease, and get cardiologists involved a bit sooner in some of our patient groups? Yeah, certainly. If you look at that session where we talked about endothelial dysfunction and these kind of associated conditions, certainly there seems to be an increased risk of all of these things amongst themselves. So, for instance, if you have ED, as we're saying, you're higher risk of cardiovascular disease, you've got a higher risk of infertility. Obviously, you wouldn't do infertility semen analysis in everyone. You would choose it, wouldn't you, risk stratify. But yeah, I think we should be. The evidence is out there. We should be looking for these patients and trying to deal with them early, as opposed to waiting for them to either develop heart failure or have an MI or whatever. The panel are getting a bit nervous if they have abnormal semen parameters that they're going to die. That was. Yeah, well, that's fair enough, I'd say. Yeah. Okay, any other questions? All right, I'd like to thank you very much, and lovely slides. Thank you. I'd like to invite Tom Walton to the podium. He's a legend in his own lifetime, so most of the urology trainees know him for his fantastic notes. They get them through the FRCFs every year. However, his day job is he works at Nottingham City Hospital. He's subspecialising in minimally invasive surgery, prostate and renal cancer. And he's going to educate all of us because he's going to talk about Latitude, which I always thought was a music festival in Suffolk, but in fact it's a randomised controlled trial in prostate cancer. And Spartan, which I always thought was a Greek warrior, but I'm about to learn about that as well. So thank you very much.
Thank you, Suzanne. The oncology programme at BAUS this year has been extremely high standard. Congratulations to Joe Cresswell and the Executive Committee for putting together such a good programme. We were especially honoured we had Professor Alan Partin, who came to give an overview of prostate cancer biomarkers shortly before receiving the St Paul's Medal. And we also welcomed Dr. Francesca Pisano, who presented her group's work on the role of re-resection in high-grade bladder cancer. I've been to all of the sessions, and I can say that having been there, there's been a number of themes that have cross-cut throughout all of the sessions. One of them has been the use of innovative technology to guide patient counselling and decision-making. We've seen web-based apps to support patients. We've heard about option grids, and we've also had a digital glimpse into the future of personalised medicine. But the trial that I wanted to focus on was the Predict Prostate Initiative by Vincent Nanapragasam and David Thurtle at Cambridge. They looked at data from over 10,000 men who were diagnosed with prostate cancer from 2000 to 2010 in the East of England Cancer Registry. The data set was remarkably complete, with comprehensive data on stage, grade, primary treatment modality, and prostate cancer outcome. They allied it to HES data for patient readmission, which was linked to comorbidity index, and then they used that data to create a multivariable nomogram. That had age, PSA, stage, grade, number of cores that were involved, and the type of treatment. And correlation indexes were extremely high for both 15-year prostate cancer-specific mortality and also overall survival, respectively, and performed better than a number of already published nomograms in the literature. They then validated that cohort in a Singaporean cohort of 3,000 patients with diagnosed prostate cancer, and the C indexes were actually slightly higher. The only criticism to date is that 97% of the patients were white Caucasian, and so this cohort, this nomogram has not been validated as yet in a Black and Afro-Caribbean population. The data has been used to produce an online calculator, and some of you maybe have gone down to the exhibition hall and used the online calculator. It's going to be freely available later on this year, and I think it'll go a long way to aid decision-making, both in the MDT setting, but also when we see our patients in clinic. The second cross-cutting theme has been the use of innovative initiatives to improve the utilisation of NHS resources. We've heard about initiatives to improve day case TURBT. We currently perform only less than 10% of TURBTs as a day case. The Portsmouth guys presented their data to suggest that you can get up to 80% safely. If we adopt a promise-based pre-biopsy PSA pathway, we can save up to £170 per patient seen. And also we've heard that it's safe to discharge our patients after 1 year of follow-up for low-risk bladder cancer, provided they don't have a recurrence, but in fact only 45% of us across the country do that. The trial that I was going to focus on is the Calibre trial. It's a relatively small trial, and we don't often present negative results, but I think it's worthy of comment. It's a phase 2 ICR-funded UK multi-centre trial, and it was specifically looking at the role of chemoablation to try and reduce the number of TURBTs that we're doing on patients with recurrent bladder cancer. So 55% of patients were G2, 80% of patients had a solitary recurrence, 99% were less than 3 centimetres. Patients were randomised in 2-to-1 fashion, 4 weekly installations of mitomycin C versus a standard TURBT. Primary endpoint was response rate at 3 months, as defined by both visual analysis and also biopsy. The trial was closed early. The recruitment was difficult, only 82 patients over 37 centres. and it was stopped because there was it didn't achieve the target for a perceived benefit for chemoablation of 45% response rate. You can see that the response rate was only 37% versus 80% for TURBT. I think it's worthy of two comments. First is that when we think we've done a complete resection for recurrent low-risk bladder cancer, we're leaving 19% of patients with likely residual tumour. That's the first comment. And the second is that the mitomycin was well tolerated, and I think chemoablation will still have a role for the patient that's unfit for TURBT with a symptomatic bleeding bladder tumour. The final study that I wanted to highlight from BOUS this year is POUT, presented by Alison Birtle. A lot of you may have heard of it already. It won the best overall presentation at EAU this year. It sought to examine the role of post-operative adjuvant chemotherapy in patients with T2 and above upper tract urothelial cancer after nephroureterectomy. Patients were randomized. Well, the eligibility criteria was you had to have a GFR of more than 30, you had to be performance status 0 and 1, and you had to have a predominant transitional cell carcinoma component. Patients were randomized in one-to-one fashion to 4 cycles of adjuvant gemcitabine and cisplatin, or if your GFR was less than 50, gemcitabine and carboplatin versus surveillance only. And the primary endpoint was disease-free survival, and that did include patients with bladder cancer. Secondary endpoints, progression-free survival, overall survival, and toxicity. In total, 248 patients were recruited from 57 UK centres. This was a UK-conceived, led, and delivered trial. And we should be very proud of it. It was closed early on advice of the Independent Oversight Committee, as there was a significant benefit of effect. In terms of the patient profile, 90% of patients were T2 and T3, 91% were node negative, and there was a significant disease-free survival benefit with a hazard ratio of 0.49 for chemotherapy, as evidenced by the Kaplan-Meier curves, which were very kindly presented by Alison. You can see that the metastasis-free survival is almost identical, suggesting that the improvement in progression-free survival is not down to bladder cancer recurrences. Overall survival is immature and will be presented in due course. So I think the important thing to mention is that the gemcitabine and the carboplatin group, the evidence of effect was preserved, albeit in a lower number group and with wider confidence intervals. So I think taken together, this establishes neoadjuvant chemotherapy as standard of care for patients that have T2 and above upper tract urothelial cancer after a complete resection of upper tract urothelial cancer. Okay, moving on to highlights of the last 12 months. There's quite a lot, so I'll try and whiz through it as best I can. Earlier this month, the long-awaited Carmina trial was reported. It randomized patients to cytoreductive nephrectomy within 28 days of diagnosis, followed by sunitinib therapy, 4 weeks on, 2 weeks off, or sunitinib alone. It was powered to detect non-inferiority, and it was stratified according to the MSKCC risk stratification, which was the preeminent stratification at the time. Recruitment was slow and incomplete. Only 450 patients of 576 were recruited over an 8-year period from 80 centres, predominantly in France. There were no good prognosis patients within that group, presumably due to recruitment bias. And there was quite a lot of contamination. So 16 patients in the surgery group never underwent surgery, and 40 never received sunitinib. 11 in the sunitinib-only arm didn't receive sunitinib, and 38 ended up having a cytoreductive nephrectomy. The results, however, have shown no obvious benefit for cytoreductive nephrectomy. And in fact, the median overall survival was slightly higher with sunitinib alone. So it's difficult, it's quite controversial. Certainly the editorial in the New England Journal of Medicine suggested very strongly that we need to be very careful about who we stratify. I think it's important to point out this is not for good prognosis patients. Okay, staying with advanced renal cell carcinoma, the Checkmate 214 was published in April of this year by Motzer and colleagues. It sought to examine the role of two different checkpoint inhibitors, nivolumab and ipilimumab, versus standard of care, which was considered to be sunitinib for advanced renal cell cancer. They randomized 196 patients in a 2-to-1 fashion. They received nivolumab and ipilimumab every 3 weeks for 4 cycles, then followed by nivolumab every 2 weeks thereafter until patients progressed, versus sunitinib. In terms of the results, there was a clear benefit of effect for combination therapy with ipilimumab and nivolumab. The response rate was 40% versus 27% for ipilimumab. And in fact, there was 9% of complete responses in the combination arm versus 1% in the sunitinib arm. There was also corresponding improvements in median progression-free survival and median overall survival as well. And in addition, ipilimumab and nivolumab was better tolerated. As a result, the EAU guidelines have published an addendum and have changed their recommendation for patients with intermediate and poor risk advanced renal cell carcinoma to recommend ipilimumab and nivolumab. It's still not been approved by NICE yet, but I think the real difficulty will be how we're going to fund this long term. So just to give you an idea about costs, a year's therapy with ipilimumab and nivolumab is £146,000. The median duration of treatment was 8.5 months in this trial, so you're talking about £100,000 per patient. In March of this year, the CAP randomized clinical trial was published. It was allied to the PROTECT trial. GP practices rather than patients were randomized around 8 PROTECT trial centers. If you were a randomized GP practice, your patients were then sent an invitation for screening for a PSA test. And if your PSA test was above 3, then you got entered into PROTECT for your 10-core prostate biopsy. In total, just under 190,000 men were diagnosed, were sent an invitation letter. 40% turned up, of which 36% underwent a PSA test. Of those, 11% had a PSA above threshold, and then 85% of that number went on to have a Truss and biopsy. Not surprisingly, more prostate cancer was picked up in the screening arm, and patients were diagnosed at an earlier stage and had a lower, earlier age and had a lower stage and grade. But despite this, at a median overall survival of 10 years, there was no significant difference in cancer-specific mortality. Moreover, of 549 patients that died of lethal prostate cancer, 188 were in the screening arm. 36% of the patients that attended for screening would have been missed on the basis, and all of those were because the PSA was below threshold. So this stimulated a lot of interest in the media. This is a headline from The Sun on March the 13th. The subheading is interesting. I've certainly had patients who have come to me and said, my GP won't give me a PSA test anymore because they said that this trial's come out and there's no benefit of effect. And I think we need to be very careful about how we advise our primary care colleagues, because after all, it's worth reiterating, only 36% of patients actually underwent PSA testing, and this is a trial of screening, and there was obviously no benefit for screening. So in the interest of time, I'll just skip through my second slide. Right, moving on to another trial. July of last year, Fossati and colleagues published an exhaustive, very stimulating, systematic review of lymph node dissection in the context of prostate cancer. So they screened a little under 4,000 studies, 66. They managed to whittle it down to 66, containing about 275,000 men. They followed PRISMA principles and performed a risk of bias assessment for all of those patients. And then they stratified the outcomes according to oncological, perioperative, and functional outcomes. Of the 66, only 3 trials were randomized control trials, all performed in the extended versus limited cohort, and only 1 reported on oncological outcomes. They found that overall the data was poor, but the headline finding was that there was no evidence of an oncological benefit, either for lymph node dissection versus no lymph node dissection, or for extended lymph node dissection versus a limited lymph node dissection. What they did find as a positive finding was that intraoperative and perioperative outcomes were worse, so you were more likely to have bleeding, complications, and lymphedema and lymph leaks if you have the lymph node dissection. This is a very controversial area, as I'm sure you know. There'll be proponents of a lymph node dissection for staging, and there will be acolytes of the Johns Hopkins data which show that there's long-term PSA-free biochemical survival at 10 years for patients with low-volume lymph node disease. I think we have to say that there's no definite evidence of benefit for lymph node dissection, and it remains unfortunate that we've not been able to deliver decent quality level 1 evidence in this setting. Now, it gets more and more complex, metastatic prostate cancer. So in June of last year, New England Journal of Medicine published 2 dual papers. One was Latitude and one was Stampede, looking at effectively the same thing in a slightly different populations. So effectively, they're looking at the role of abiraterone with prednisolone in addition to androgen deprivation therapy for patients with newly diagnosed metastatic prostate cancer. The Latitude trial was a slightly purer trial because they looked at patients with either bone metastases or visceral metastases, whereas the Stampede trial contained 52% of patients with that, but also patients with node-only metastatic disease or patients with locally advanced non-metastatic disease. Patients were randomized in a one-to-one fashion. The results are very similar. In terms of the adverse effects, there were more adverse effects in the combined group, and that was predominantly due to mineralocorticoid effects, so hypertension and hypokalemia. But the progression-free survival was improved, and the overall survival was very similar in both arms. There was a benefit of effect of about 38% in both arms, as evidenced by our Kaplan-Meier curves. So it's difficult. The Stampede group have also looked previously at the role of docetaxel in this exact group of patients, and they found that their relative risk reduction in that group was only about 22%. So particularly given the toxicity profile is better with abiraterone and prednisolone, we have to assume that this will become standard of care before something like enzalutamide come in the trials may well supplant abiraterone in this setting. My final slide, you'll be pleased to know, is on Spartan and Prosper. So both of these studies were reported in abstract form at GU ASCO this year, and they have looked at the role of novel agents in a hitherto barren area of licensed drugs. So in patients with non-metastatic, newly diagnosed, castrate-resistant prostate cancer. So patients were either in the Spartan arm, they were randomized to apalutamide, 240 milligrams once a day, versus placebo in a 2-to-1 fashion, and the Prosper trial looked at enzalutamide. Patient populations were very similar. To get into the trial, you had to have a PSA doubling time of less than 10 months. So time to progression was advanced, and metastasis-free survival was markedly prolonged in both groups. Apalutamide has just been approved by FDA, and it won't be long before enzalutamide has. Neither drug has been approved in either the EU or the UK yet, but again, it won't be long. Enzalutamide currently costs £3,000 a month. And if you think about patients with an extremely prolonged metastasis-free survival of 36.6 months, again, you're talking about £100,000 per patient. I'm going to leave it there. Thank you for your attention.
I'd like to open the floor to questions. If you can make your way to the microphone, please.
I have a question.
Yeah, thank you.
Actually, first a comment. It seems like the entire rise in the NHS budget is going to go towards these drugs. That's just an observation. But the thing that stands out is the complete responses in kidney cancer with your double combination drugs that I can't pronounce. Because that is something new, isn't it, in these pathway interfering drugs? The systemic treatment generally has been controlling perhaps some partial responses, but not the complete responses. So this is a game changer, do you think?
It's difficult to know. I mean, historically, the interleukin series showed complete responses, and then it never really translated into a significant overall survival benefit. So I guess it's difficult to know. There were big populations of patients, so I mean, I think we have to assume that they're genuine. Presumably, these patients will relapse at some stage, but I don't know. It's difficult to know from the trial. There's not any additional data in when you read the papers about it.
Okay.
Okay, Viru?
Tom, so we have the ERSPC trial, the PCLO trial, and the CAP trial, and slightly different results.
Yeah.
How do you put the CAP trial into context with the other two, and for the audience to understand what to do?
Yeah, I think it's really difficult. I mean, the uptake is not the same. You know, it's a low uptake, and the ERSPC trial routinely perform PSA tests. So the patients were invited on more than one occasion, and that's why you saw, I flicked through the slide, but those 64% of patients had a PSA test in the ERSPC trial. And in fact, if you look at the curves, they did diverge after 10 years. And so when you're looking at populations such as the Gothenburg cohort, which have got very long follow-up, you do actually see an improvement in benefit for screening for survival, but the numbers needed to treat are so high that doesn't. There's no way that we could utilize our resources to benefit patients in that way. But interestingly, the benefit of effect for the Gothenburg trial is akin to the benefit for patients with breast cancer, for instance, in the UK, who do have a screening trial. So I think it's very different. But I think that the message from that trial is, yes, there's no benefit for asking men of 50 to 69 to screen them with a single PSA test, because most of them won't bother to turn up for it, and those that do, there's no evidence of benefit. So I think we just need to be very careful. That is a very different population to men that turn up to their GP and ask for a PSA tests that are motivated to do it. There was no analysis of as screened or as tested population in that trial, so difficult to know.
Following on from that, can you explain to us how this negative trial doesn't seem to have had any effect on the demand for our services, and in fact, it's been quite to the contrary recently?
Yeah, well, that's the Stephen Fry and the Bill Turner effect, isn't it? Turnbull effect, isn't it? And that's why we've seen it. I'm sure we've seen it in all our departments. You know, after that happened, we've had a huge spike in 2-week wait referrals for PSA, and that's patients going to see their GP. Well, that's a different population to the one that's been presented on. I mean, this is a negative trial of a single screening test offered to men at the age of 50 to 69. So I don't think we can compare.
So if you were to, let's say a doctor, a patient says, I'd like to be screened, or I'd like to undergo testing, I should say, then would you say check it annually for a few years? Between what ages? You know, what would you advise?
I think it depends on their age. So the EAU guidelines have been very specific about you know, when to test. So potentially patients with a risk could be tested at 45. So if they've got a positive family history, if they're Black and Afro-Caribbean, if their PSA is above a certain threshold. Andrew Vickers has shown that actually we can stratify patients in terms of their lifetime risk of getting prostate cancer based on their PSA at a low age, 40, 45. And then they can have a risk stratified screening accordingly. So if somebody comes to you and asks that, that's effectively what I say to them. Depends on age, though.
Okay, thank you very much. And finally, I'd like to ask Cassie Vizvanathan to take a stand at the podium. I've practiced that about 20 times as well. I'm really sorry. He's a rising star, really, in the world of prostate cancer. So he's currently a urology registrar at West Hertfordshire NHS Trust. He's chairman of BURST, which is the research collaborative group with the urology registrar trainees. And during his fellowship and PhD, he looked at MRI-targeted biopsy in the diagnosis of prostate cancer. And during that time, he developed and then delivered the Precision study, which he's going to tell you about more now. Thank you.
Good afternoon. It's with great pleasure that I can present the results of the Precision trial, which is a British-led study. So this is really due to the work of a number of investigators across 11 countries in 25 centres, and some of the investigators I can see are sitting in this room today, so thank you. So what do we know about the role of MRI in prostate cancer? So every conference you go to, there'll be posters and talks on this. It was almost a decade ago that Arnaud Villet from the Lille group first really proposed this idea with some solid evidence. He showed that there was a 95% negative predictive value for ruling out a 0.5 cc lesion on multiparametric MRI. We've had developments in the standardization of MRI with guidelines such as the PIRADS version 2 scoring system. There have also been randomized trials which have shown the benefit of using MRI in a diagnostic pathway. However, not all of the studies have supported this. This explains why in both the NICE guidelines and the EAU guidelines, MRI is not recommended prior to a biopsy in biopsy-naive men, but they do recommend it before a repeat biopsy. We know that the standard of care trust biopsy has limitations, and the PROMISE study demonstrates that very well. While PROMISE tells us how good MRI is, it doesn't necessarily tell us how to use that information in a pragmatic setting. So 4 years ago now, we set out to design a study which we felt would. So this picture is from New York, where we derived a consensus meeting. We were hosted by Samir Taneja on the right of that picture, and we derived a study which we felt could change practice and assess whether standard biopsy could be replaced by a different diagnostic pathway. This was the study we came up with. So we randomized men at clinical suspicion of prostate cancer based on a raised PSA or abnormal digital rectal exam. They were randomized either to a 10 to 12 core trust biopsy or a multiparametric MRI with T2-weighted, diffusion-weighted, and contrast-enhanced sequences. These were scored on a PIRADS version 2 scoring system. If the score was a PIRADS 1 or 2, they had no biopsy. If the score was a 3, 4, or 5, they had a targeted biopsy only, with targeted cores to the suspicious area, with up to 4 cores per area and up to 3 suspicious areas targeted. This was the first trial in which men with a negative MRI had no biopsy, and men with a positive MRI had no systematic biopsy. So men needed to have a PSA of less than or equal to 20, a localized digital rectal exam, and no prior biopsy. The primary outcome was the proportion of men with clinically significant cancer, which we defined as Gleason grade 3+4 or greater. Key secondary outcomes included the proportion of men with clinically insignificant cancer, the proportion of men who avoided biopsy in the MRI arm, and some of the post-intervention complications. So this is the intended recruitment graph. That blue line shows what we expected, and this was actually our recruitment. So when we started the study, we were genuinely unsure whether we'd recruit at all, because in centres with expertise in MRI, they might find it difficult to randomise men to an arm without MRI, and in centres who weren't experienced in MRI, they might find it difficult to get involved in the study in the first place. So really, this is a testament to the patients and the investigators and the importance of the study question that we were able to achieve this. So looking at the patient demographics, we can see that with respect to age, PSA, family history, and abnormal digital rectal exam, baseline characteristics were similar. Looking at the primary outcomes, so 28% of men avoided biopsy in the MRI arm. There are a median of 4 cores taken in the MRI arm compared to 12 in the trust biopsy arm. For clinically significant cancer detection, 38% of men have this detected by the MRI arm, compared to 26% for the trust biopsy arm. And no matter how you analyze that, the message is pretty clear. Not only was MRI plus targeted biopsy non-inferior to trust biopsy, it was superior in the detection of clinically significant cancer. Looking at some of the secondary outcomes, for clinically insignificant cancer, which is something we want to avoid, MRI and targeted biopsy detects fewer men with clinically insignificant cancer than trust biopsy. Maximum cancer core length was slightly greater with the MRI arm, and the proportion of cores positive for cancer was greater in the MRI arm. with respect to the 30-day patient-reported complications for fevers, hematuria, hematospermia, blood in the stool, erectile dysfunction, and pain, these were all more favorable in the MRI arm. So to summarize the main findings, the MRI targeted biopsy strategy resulted in fewer men needing a biopsy with fewer cores, more clinically important cancer being detected, less clinically unimportant cancer being detected, and a more favorable 30-day patient-reported complication profile. So this was a large, multi-center international study. We permitted non-expert centers to take part. 1.5 Tesla MRI was permitted. The operators in the MRI targeted biopsy actually had quite a modest experience in the technique compared to the trust biopsy operators. And we allowed a range of different registration techniques to try and reflect real-life clinical practice. We accept that in men with negative MRIs and in men who avoid a systematic biopsy, there will be some clinically significant cancer missed, but from the literature, we believe that this proportion is low. We also acknowledge that the radiologists in the study were experienced, reporting a median of 300 scans per year. So to summarize the main findings, in biopsy-naive men with clinical suspicion of prostate cancer, a diagnostic pathway involving pre-biopsy MRI risk stratification and MRI-targeted biopsy is superior to 10 to 12 core trust biopsy. So how do we go from there? Well, it's clear that we need to train the workforce to be able to use this technology. The second thing is we need to improve the standardization of MRI reporting. From the report, it's clear that there's variation in this. And perhaps one of the biggest changes is a change in healthcare service allocation to allow an increased capacity for multiparametric MRI. And the full paper is available online. Thank you.
Okay, thank you very much. So again, we'd like to invite questions.
I had a naive question, which is, I'm here, over here, anyway. If you were talking about MRI targeted, I'm over here, yes. MRI, used for guidance. We're not talking about doing this biopsy on an MRI scanner real time. We were using it as a map and then using template to try to, is it ultrasound guided biopsies in the end?
Correct. So of the three broad types of MRI targeted biopsy, you could have MRI in bore, which this wasn't, or you could have ultrasound guided, but prior to that you have some MRI information. You can use visual registration, so the operator remembers what was on the MRI and uses that in the procedure. Or you can have software assisted, where you have image software that superimposes the MRI image on the ultrasound in front of you. And it was those two that were included in this study.
And was there any difference, or is there any evidence to say one is better than the other?
So the evidence in the literature from even randomized trials in this area presented at EAU show that there's no significant difference between visual registration, targeted biopsy, or in bore in cancer detection rates. When you look at the trial, it wasn't powered to look at that subgroup, but if you look at the actual figures, it does look like with the software-assisted, the detection rates are slightly higher, but the confidence intervals are quite wide, so you wouldn't see a statistically significant change in that.
Okay, my question is about the patients who have a negative MRI. Are you following those patients up? And how long do you plan to follow them up? Because obviously you don't really know whether or not they do have prostate cancer.
Sure. So as part of the consent process for the trial, they all consented to follow up with linkage from national databases. So they will be followed up, and we'll look at that data in 5 years. In terms of what happens to these men in general, this trial has a small proportion of men compared to the many hundreds of men that we may be doing this in. So there is data out there that does support this approach. So the Pane-Bianco paper published a month and a half ago in European Urology followed up around 1,000 men with negative MRIs, and at 5 years, 95% were free of significant cancer.
Thank you. We have a question at microphone 1.
Thank you. Congratulations, Will, for an excellent study, which has clearly shown that MRI targeted biopsy is superior to trust biopsies. do you think you need to do a similar study to compare MRI-targeted biopsies with systematic transperineal biopsies?
Okay, so some of the targeted biopsies in this study were done transperineally. There were also some were done transrectally. The majority were done transrectally. We know with systematic transperineal prostate biopsy, you will get a high detection rate of cancer. I think the issue with this is it feasible to have a service where you do that in all of your patients? There's increased burden to the patient with complications, there's increased burden to the pathologist, and it slows the pathway down. So is there a pathway in which you can avoid some of those things whilst maximizing your important cancer detection, minimizing your unimportant cancer detection, and some of those other complications? And I think this solution is probably the best compromise between all those things.
Would the floor agree? Does everybody agree? The experts in prostate cancer diagnosis, would they agree? I'll leave it open. Thank you.
Okay, and thank you. Microphone 2.
Just further to what Mo asked you about negative MRI, shouldn't we be more worried about the negative TRUS patients?
Absolutely. So in answer to a question about are you worried about the negative MRIs, let's look at what we've been doing with the negative TRUS biopsies for decades. And we know from PROMISE that the negative predictive value of an MRI is better than the negative predictive value of a TRUS biopsy. So the negative TRUS biopsies we follow up with standard of care, refer back to GP, PSA surveillance. Likewise with negative MRIs, the same approach could be adopted, and once a patient has a PSA, it's a PSA for life.
And in terms of adoption, are you able to, from this study, tell us how many patients would have had a PIRAD 1 or 2 if they hadn't had contrast?
Not from this study, because all of the MRIs had the 3 sequences taken together, and the MRI was interpreted on basis of that information. The value of contrast is an interesting question, which we're designing a trial to answer. The BIDOC study, which was published in JAMA about 2 weeks ago, showed that the results from biparametric MRI are very promising. We've seen the PIRADS version 2 update in European urology also in the last few weeks, where they actually recommended in biopsy-naive men you still do multiparametric MRI. So I think it's an area of controversy, and we don't know what the answer is at the moment.
Oh, Dominic, microphone 1.
Thank you. Dominic Hodgson, Portsmouth. Does your data tell us any more about what to do with PIRAD 3 lesions? Do we include those with 4 and 5s, or can we not biopsy some of these?
Yeah, so around 11% of men with the PIRADS 3 had clinically significant cancer. So we didn't use any additional PSA derivatives, which since the start of the study have shown quite good value in allowing a decision as whether or not to biopsy men. I think at the moment clinicians are getting around their heads not biopsying PIRADS 1 and 2s. Not biopsying PIRADS 3s is perhaps a further leap, though we have published data on this. This is an approach that we do at our centre, and we followed those men up for a short time period. In a short time period, it's a safe approach to take. There is further information, so PSA density I think is a really useful adjunct that clinicians can use from the information they have that they get from the patient anyway. Every MRI will have a volume and you'll have the PSA, and a cutoff of around 0.15 for a PIRADS 1 or 2 seems to be a good threshold. If it's above that, you may want to consider a biopsy. For a 3, I don't think we know what that threshold is, but we have the data from PROMISE for sure to be able to answer that.
I've just got one question, Veer. Can you tell me what the PSA thresholds for referral into your trial was? You may be aware that it's quite controversial now that there is a move to reducing the threshold for men between 50 and 59 to 3 micrograms per litre, which will have a major impact upon the number of referrals we'll see in our department. Do you have any idea about what was the PSA threshold for those patients?
Yeah, so we didn't insist on a minimum threshold. We left it to the clinician's local practice. So we said, based on their clinical suspicion, whether they felt the patient had warranted further investigation. So there would have been men with a PSA lower than 3 in there, but the majority would have had, as you saw, the median PSA was around 6. So, yeah.
one more practical question in terms of what this means for us. We in Bristol have actually done very well in getting our expertise in MRI reporting. We've actually got fantastic capacity now for MRI, so we've got a just very streamlined process, but it all falls down because of our transperitoneal template biopsies are stacking up. And do you have any solution to that problem?
I do. So one of the things that has got more attention in the last few years is local anesthetic transperineal biopsy. So Precision Point is a reasonable device which I've used, and it seems like it's a feasible solution in a clinic type setting. You don't need an anaesthetist with you, and you can get transperineal sampling, and we saw at this conference Rick Poper present his data on that, which showed some good detection rates. So I would suggest local anesthetic transperineal, if that's the route that you want to go down for biopsies, is a reasonable solution for that.
Okay, microphone 2.
Thanks for the talk. I come from Basildon, and the point you made about MRI reporting is very valid. We get a lot every week, probably 1 or 2, maybe 3 a month. Normal MRI, trust biopsies showing significant cancer, Gleason 4+. Gleason, Gleason 4+4, 4+5, and a normal MRI reported. So MRI reporting is by radiologists, you need to be really precise, and you can't exclude people on. In our practice, we don't exclude them even if they have a normal MRI scan. We still do a trust biopsy, and the trust biopsy can show it. Sometimes templates show it if the PSA is still raised.
So I think for your average centre, there's a number of steps that need to be taken if you want to adopt this pathway. The first would be optimising your MRI sequences. So at UCL, we actually offer an MRI outreach service where our radiographer goes down to the local centre, looks at their MRI protocols, helps them optimise the images to get MRIs to a good quality. That's the first step, even before the radiologist looks at the scan. Second thing is training the radiologists in doing this, and the EAU will most certainly have a big push in training the European workforce in trying to do this, and you'll see that the MRI reading courses have been popping up around the place, and if you want to go to one, there is one this year in September at UCL that we are running. With those two things, I think you have to start there and audit your own work and see exactly, as you've noted on a couple of cases, how does it perform over a couple of 100 cases at your unit, and do it after you've optimized the images and see what you get. And if you feel comfortable based on your own data, then that's a reasonable time at which you can move. But I would recommend everyone at their average centre does audit their own data.
Okay, thank you very much. So I'd like to thank very much all our speakers today that have put a lot of effort into reviewing quite a wide range of literature and other resources. So thank you to Frank Healy, Mo Bilal, Ari Parnham, who's had to go, Tom Wharton, and very Kazu Viswanathan. Thank you very much. I think BAUS has been really excellent as a delegate, and I've been going around, obviously, for the highlights as well. Such interesting range of topics, and the innovation, I think, is probably what's going to be included in highlights. So we've had some excellent talks. Professor Toby Young has explained how these kind of new approaches are really going to affect our urological practice. So that's something to look forward to in the future. We will close this session, but I would strongly encourage everybody just to stay. We have finished the session early, and I can see our Vice President, Duncan Summerton, is in the audience. And if you'd like to stay, Duncan will now conclude with the closing remarks of BAUS. Thank you very much.
Slides, please. Okay, so essentially, just to give you a bit of an idea about what the meeting's been, there's a lot of stuff goes on behind the meeting that I think some of you are aware of, but some of you aren't. And I just wanted to go through a bit of statistics I think Liverpool's been a fantastic venue again, I think you'd all agree with that. And we've had 1,034 delegates registered, which is great news indeed. You can see there's a wide spread of delegates from throughout the world, not just UK, which is lovely. The abstracts, there's 524 abstracts submitted. I said the quality of the abstracts are good. The acceptance rate is 31%, and 160 abstracts were presented during the week. 65 people are involved in marking, sorting, deciding which sessions they should go into, and they should deserve great thanks for sort of putting all those things together. We had 17 overseas guest speakers and representatives. We like to involve people when they come to BAUS. If they come from a long way away, we get them to chair sessions, give keynote addresses, get involved in committees. And I think people actually like that, get the social environment sorted out as well, and I think our guests appreciate that. And it's thank you to everybody for making overseas visitors feel so welcome. I think it's been a real buzz around this meeting, actually. I don't know if you agree, I'm just probably biased, but I think it's walking down the corridors, everybody's really seemed energized by the potential and the future that BAUS has got to offer people. We've had 89 chairs involved. We try to match a senior old guy with a younger lady or vice versa, just to get the new blood coming in and chairing sessions and demonstrating their chairing skills. And there's a course before BAUS for those who haven't chaired sessions before, which is very well attended. Most of the 7 courses, we cut down the instructional courses. There were only 7 this year, but most were sold out way before the meeting. 2 weren't, but then became sold out just during the meeting. So everything was sold out, which was great. It's also a great meeting point to liaise with all the organisations within neurology, and these are the organisations here. And I apologise if I missed any, but I think that's basically who we've interacted with this week, which has been great. Industry, whatever, keeps this meeting going. 70 as ever, 73 companies exhibited, and I think a lot of you did visit the stands. The feedback from the industry certainly was good. They had an option at 8 o'clock this morning to come and tell us anything that was negative, and nobody turned up. Now, whether they're just still out the night before, or whether actually they don't have any grievances, that's good news indeed. I'd like to thank all the sections in this, the Education Committee, the sections, or the committees, all the chairs, everybody. You've really given a lot of effort and time into this, and it's very much appreciated. Paul and Assi for really put this together, and with great support from Hannah and Harry, as ever, and it's gone ahead very nicely. The Tough Cycle Ride, well, you know, what a group of people, fantastic. 13 hours, just under 14 hours to go. I think it's about, I don't know how the distance was, but it's very steep and it was very hot. So well done, and they've raised over £55,000 for charity, urological charities, which I think is very commendable. So, I'm not very social media savvy, but I'm told there are 2.7 million impressions. Now, an impression, I believe, is not actually a view of a page, but it's the number of people that the tweets reached, essentially. So 2.7 million. Doesn't mean to say 2.7 million tweets were read, but nonetheless, it spanned out over the world. 2,015 tweets, 505 active tweeters, and 3 tweets an hour on average during the meeting, and 4 tweets per participant. I'm sure some people tweeted a lot more than that, and I'm sure there's a league table for the best tweeter, but I'm not privy to that information. The app, I think, has got better this year. There's 1,000 downloads, which is more than the number of delegates. That's probably explained by people like myself trying to load it twice because I didn't know how to do it. 70,000 page views, and when it's been used, the app's been used in sessions, more than 85% of people have taken the benefit of voting during that session, which I think is a fantastic sign of engagement and utilisation of new technology. So good feedback from that, and we just thank Felix Stroud-Allen and Matt Allen from Crowdcoms for sort of developing the app. I think the AV's been pretty good. There's been 1 or 2 little niggles, there always are, but they've been really well sorted out by Nigel and his team from Clark Events, so thank you very much for that indeed. BAUS is all about people, isn't it? You know, it's a great place to meet people, and these people here, you recognise all of them, I'm sure, or most of them. They're the backbone of BAUS, and I'm not going to go through individual thanks, but they've all put a tremendous amount of effort and work into this meeting, and indeed your organisation. The permanent staff are a great support and a great team to work with, and they make sure that we keep on the straight and narrow. And Kieran's had great support from these guys, and I do too. So it's really good news indeed. Next year, you will all get a survey, a detailed survey sent before you get your CPD certificate, which is a little thing. Please be honest, the free text is particularly valuable. They are all read. We read these, and we have a wash-up meeting in the middle of July to inform, going forwards, what we're going to do next year. So get your comments in early and they will be taken notice of, and we'll try and adapt things. If you've got any ideas for the whole theme of the meeting, programs, sessions, if you want to volunteer to do things, just put your name forward, put your head above the parapet, and you will be taken on within limitations of the program. So you can get to that by your regional reps, by the BOUS office, by ourselves, anybody. Just make yourself known. Give us your ideas and we'll try and accommodate those. Glasgow is next year. It's not the most popular destination, I have to say, but I think people who do go do enjoy it and stay for a bit longer because it's a little bit further away. So it's a great city, it's a good conference centre. Please support us, please come to BOUS. Keep your diary clear for the 24th to 26th of June 2019. You're all very welcome to come. It's been great to see you. Thank you for engagement and participation, and see you next year, hopefully. Thanks so much.
Whatever you